Hello, my name is Monica Delodope and I will be presenting a case study on Naegleria fowleri, presenting as an amoebic encephalitis. The patient was a 74-year-old immunocompetent man from Nepal. He had no history of swimming or travel. He had 4 days of low fever and 2 days of headache. He also had hypertension. He was mistakenly diagnosed with herpes encephalitis instead of amoebic encephalitis. The patient was given treatment and an MRI scan. His MRI showed that he suffered from swelling and a lesion on his left temporal lobe, along with some areas of small bleeding. In addition to low fever, headaches, and the small isolated areas of bleeding in his temporal lobe, no history of swimming or travel. All these factors led the doctors to believe that the patient had herpes encephalitis. He was also given a CSF or cerebrospinal fluid test. The results showed he tested negative for many of his investigations. Here is his second MRI. As you can see, his lesion increased up to the posterior limb of the internal capsule and still some hemorrhagic areas. Another CSF was done. He tested negative for many of his investigations, and others that were tested positive was determined to be normal. Slowly, he began to improve over the next week. He was discharged after the completion of his treatment. 10 days after his release, the patient returned to the hospital because he was vomiting blood. At 6 weeks, another MRI was performed. The results showed that he still had a lesion in his left temporal lobe. He also had lesions in his right hippocampal and midbrain area. The patient's condition worsened and he had to be intubated. At this point, a brain biopsy was done. The results showed that the individual had necrosis and clogged arteries. Slides of the brain biopsy revealed the trophozoite form of Naegleria fowleri, engulfing red blood cells. After this discovery, doctors began treating the patient correctly, but after 7 weeks of the onset of his disease and 10 days of his new treatment, the 74-year-old patient died from the brain-eating amoeba. So, how did this happen? The free water-living thermophilic amoeba enters the human body through the nasal cavity. The amoeba passes the olfactory nerve and reaches the olfactory bulb in the central nervous system through the cryptiform plate, which is porous in children and young adults. Naegleria enters the body as a trophozoite. Structures on the surface of the trophozoites, known as food cups, enable the organism to ingest bacteria, fungi, and human tissue. The amoeba depends on enzymes such as phospholipases and neuraminases to thrive in its host. In turn, the host tries to fight its invader by activating an intense immune response. This causes damage to the brain and results in death. In the US, Naegleria fowleri has a 97% mortality rate. So how do you know if you're infected with Naegleria fowleri? Signs of infection start within 24 hours or within 2 to 8 days. The most common symptoms are fever, chills, confusion, and many more. So why is Naegleria fowleri spooky? Because it can be hard for medical professionals to detect, and completely healthy individuals can die from this infection.
Hi, my name is Hajar El-Alam and I'm presenting the first description of Naegleria fowleri. It was first described in 1965 by M. Fowler and R. F. Carter and was published in the British Medical Journal. The first 3 case studies of a 9-year-old boy and 2 8-year-old girls were so similar that they were presented collectively. First symptoms appeared on the 4th day before death. The children were described as being lethargic and disinterested in their usual activities. Day after they all displayed symptoms of having a fever, complained of a severe headaches, sore throat, and a blocked nose, and they were then diagnosed with an upper respiratory tract infection. By the end of the 3rd day, they were admitted to their local hospital with a provisional diagnosis of acute meningitis due to the onset of severe vomiting and an impaired level of consciousness. And they confirmed this by performing a spinal tap and found purulent cerebrospinal fluid. Deepening coma and signs of cardiorespiratory failure led to their transfer to the Adelaide Children's Hospital, where they all arrived and died shortly after their admission. The only amoeba that was generally recognized as invading human tissue at the time was Entamoeba histolytica. Meningitis as a complication by this amoeba was occasionally reported, but there was always evidence of primary bowel invasion that had been present, and also the morphology of the organism was quite different, as you can see from this picture provided when Fowler and Carter published their findings. This dissatisfaction led them to consider other types of amoeba, and they were drawn to the genus of Acanthamoeba, which they described as comprising of many species of small free-living amoeba ubiquitously distributed in water and moist soil. But because of its ecological relationship to soil, they didn't suspect that it would affect higher animals until it was demonstrated by Culbertson, who introduced cultures of Acanthamoeba into the noses of mice, and they died 4 to 5 days after with meningitis. They knew for sure that the causative organism was the amoeba, whose presence was overwhelmingly located in the olfactory bulbs and adjacent forebrain, and its presence in the nasal submucosa and olfactory nerves, which led them to believe that the invasion of the brain and meninges was through the nasal mucosa. So they concluded that the diagnosis is of some species of Acanthamoeba as a causative agent of acute meningitis.
Hi everybody, my name is Mia Lomatown and I will be speaking of the treatments for the virus Naegleria fowleri. So as we heard from Monica, unfortunately the man in the case study wasn't able to seek treatment right away since it was very difficult to detect the virus. This is not an uncommon situation, as Naegleria fowleri rarely occurs, and if it was detected early enough, the fatality rate is so fast that doctors or scientists wouldn't have a subject to study, as the patient had already passed. Over 95% of diagnosed patients die due to mostly the late diagnosis and/or treatment. Since this isn't a heavily studied virus, due to again the rare occurrence of the virus, there have not been many drugs that have been scientifically validated for treatment regimes. The few agents that have been successful are amphotericin B, chlorpromazine, rifampicin, fluconazole, and miltefosine. So the combination of IV fluconazole added to an IV of amphotericin have significantly helped with treatment with or without the supplement of oral rifampicin. Midosols in general have showed significant activity against free-living amoebas, and fluconazole, as an example, has proven to penetrate the blood-brain barrier and have effectively reduced organ dysfunction and mortality in septic shock by increasing bacterial cytal activity and adding neutrophils. Although this combination of drugs have been successful and does seem promising, there's really not enough evidence to definitely recommend this combination of drugs. Amphotericin alone is the only agent available to treat primary amoebic meningoencephalitis, but since it is very toxic, as an antibiotic, studies are looking for alternative agents, since amphotericin affect other organs, cause renal toxicity, and electrolyte disturbances. However, it does inhibit amoebic growth. Chlorpromazine is also an inhibitor of amoebic growth, and as studies have seen, chlorpromazine is the most effective drug in vivo and in vitro, which can be used as a replacement of amphotericin, as it has low toxicity and according to a mouse study has higher survival rates, as 75% of mice survived while only 40% of mice survived using amphotericin. So the mechanism of this is unclear, but it is definitely a candidate drug. Another drug that has shown potential in treating Naegleria fowleri would be miltefosine. It is an anti-cancer drug, and it also does show defense against amoebic activity. And it is successful in early diagnosis, but not in late diagnosis. And in one case, miltefosine was used alongside a therapeutic hypothermia regime that manages brain swelling, and they have seen a positive effect where the brain has reduced swelling and has reduced the count of Naegleria fowleri. And as you can see here in the slides A and B, there are many counts of the virus, whereas C and D, there are no traces of the virus. In A and B is a brain tissue of a mouse that has died after treatment, and C and D is a brain tissue of a mouse that survived after the drug treatment. And again, A and B, C and D have a clear difference of Naegleria fowleri traces. So C and D have no traces of Naegleria fowleri after treatment.